is going to be on setting the state, key consideration before and during immunotherapy and chemotherapy treatment in early stage triple-negative breast cancer. And for this, we are honored to have Dr. Jackie Thompson from Australia. So Dr. Jackie is a medical oncologist as well as an adjunct lecturer at Monash University in Australia. So please welcome Dr. Jackie to give the speech today. Good. Yeah, I might be this involved. How to do these slides. Sorry. Yeah. Yeah. Hey. Oh, yeah. Thank you very much. Okay. Thank you very much, Dr. Yusuf, for your kind introduction, and thank you very much to MSD for inviting me to speak today, and also to the conference organisers for this wonderful conference. So these are the title of my talk, and these are my disclosures. So I think we're pretty aware of the Keynote 522 study design now. It's the 2-to-1 randomization to pembrolizumab and placebo. And I just wanted to highlight that in the key eligibility criteria, ECOG performance status had to be excellent. So either 0 or 1, and the vast majority was ECOG 0. These are the study endpoints. So importantly, 2 co-primary endpoints being PathCR and event-free survival, but also important secondary endpoints, including overall survival and also safety. So these are the baseline characteristics. As we can see, these are uniformly young patients, almost always, with excellent performance status, PD-L1 mostly positive. The tumour size, predominantly T1, T2 tumours, and split 50-50 between node positive and node negative disease. And these are the primary analyses, both in terms of the pathologic complete response, showing a significant benefit in favour of the pembrolizumab arm with a delta of 13.6, and that was irrespective of whether or not a patient was PD-L1 expressing or not. And then the event-free survival presented a year or two later, showing a significant difference with a hazard ratio of 0.63 in favour of the pembrolizumab arm. And this was updated now with 60-month median follow-up, 63 median follow-up. At 60 months, the curves had widened even further in favour of the pembrolizumab arm in terms of event-free survival, with a hazard ratio of 0.63. All subgroups were benefiting from the treatment. And then breaking down the event-free survival further, both at the 36-month and at the 60-month mark. And what we can see is that if you get a pathologic complete response, you're going to do very well. If you do not attain a pathologic complete response, you do far better if you have the pembrolizumab. Breaking that down further, what we saw was really a shift in the residual cancer burden in favour of less and less residual cancer for those patients who received the pembrolizumab. If you had RCB1, you were still going to do quite well, obviously not as well as if you'd attained a pathologic complete response. But where we saw the real benefit of the pembrolizumab in those who really did not attain a particularly good pathologic complete response to RCB2, and there was a very substantial difference. Doesn't quite project, but the hazard ratio was 0.52 in favour of the patients who received the pembrolizumab. Going on to the bottom, the right-hand side, if you were RCB3 and you were a non-responder, you were not going to do very well, sadly. These are the patients I think we're urgently awaiting further translational studies, and also these are patients that desperately need further clinical trials. So finally, and it's probably the last important presentation, was overall survival, and this then shows a statistically significant benefit in overall survival for the patients that receive pembrolizumab, far less events in the pembrolizumab arm, hazard ratio of 0.66. So I just wanted to dwell a little bit first before I go into toxicities regarding adjuvant or post-neoadjuvant treatment with immunotherapy. At the moment, we have had a few studies that have read out that did not meet their primary endpoints. Now, that wasn't with pembrolizumab, but did not meet their primary endpoints. What we are eagerly waiting on is really the outcome of the Keynote 242 study and also the optimised both pathologic complete response and the residual disease. That I think will help clarify whether or not we actually need to give adjuvant pembrolizumab in all situations. At the moment, what we do have, though, is the Keynote 522, and as we know, that had an adjuvant and a neoadjuvant. So at the present, I think that's what we should stay with that until we get further data. So moving on to immune-related adverse events, this is in all comers, all different immunotherapy. But what we can see is that pretty much any organ, most of the time, not severe, but nonetheless present, and to a greater or lesser degree. And these are the kinetics. I think this is to highlight really the endocrinopathies associated with pembrolizumab or with any immunotherapy. So this again is not pembrolizumab specific, but as we can see, the endocrinopathies occur a little bit later and can occur ongoing for many, many months after initiation of the immunotherapy. And the reason's pretty clear. It's really a burnout toxicity. So we get the immunotherapy attacking the organ, and over time then the cells that develop the particular substance then are functioning, and that's where you start to see the burnout pattern. So really that's these patients then need ongoing hormone replacement therapy, and usually it's lifelong. However, you can still safely continue the immunotherapy. Smoldering toxicities, though, is quite distinct. They're often really immune effects, off-target T-cell activation in a joint, for example, and they're the ones that would resolve if you, say, use steroids or if you do treatment withdrawal, as distinct from the endocrinopathies. So the safety assessments in Keynote 522, PCR and event-free survival, as I say, were co-primary endpoints, but safety was a very important secondary endpoint, and this was presented in 2023 at San Antonio. So the majority of the IRAEs and infusion reactions, they occurred during the neoadjuvant phase. So this was looking at the full group of patients who received immunotherapy. If during the neoadjuvant phase, 39% of patients, or 308, had an IRAE. Compare that with 60 patients, or 10%, who received an IRAE during the adjuvant phase. Importantly, there were no delays in surgery nor increase in surgical complications with the use of the pembrolizumab. Just to highlight before I go on breaking down the IRAEs with on the Keynote 522 study, the differences in adverse events between chemotherapy and immunotherapy. So, for example, with chemotherapy, as medical oncologists, we pretty well aware, it's almost all patients, it's well described, few organs affected, and very well established time pattern. As distinct from immunotherapy, the majority without, but the onset can be very variable, can affect any organ, and a very, very variable time course. So it just sort of adds that unpredictability and underscores the fact that we've really got to monitor these patients pretty carefully. So these were the adverse events in the combined phase. So this was incidence of more than 20%. So this was the neoadjuvant component of Keynote 522. And what we're seeing here, it's really what we'd anticipate for chemotherapy: nausea, alopecia, neutropenia. There's some overlap, so fatigue and anemia, for example, could potentially be an IRAE, but we generally put these all down to being chemotherapy. We break that down then to those that were specifically immune-related adverse events. This is an incidence of greater than or equal to 5 patients, as distinct from 20%. What we're seeing is the vast majority are infusion reactions, hypo and hypothyroidism, and skin toxicity. And then we see a smattering of, again, you can think of the organ and you can sometimes see an immune-associated toxicity. This is the adjuvant phase. Incidence across the board of adverse events is far less. And again, you could easily attribute a lot of those to coming off chemotherapy, particularly arthralgias, asthenia. A lot of those you could easily attribute to coming off the chemotherapy. But the specific immune-related adverse events, just to highlight, this is more or greater than or equal to 2 patients' incidence: hypothyroidism, infusion reactions, and severe skin toxicity were the most common. This slide really lists the time to onset of the most common IRAEs in Keynote 522. And what we're seeing is in line with the graph that I showed earlier with all types of immunotherapy. You're seeing colitis, skin reactions early, hepatitis earlier in the treatment. And as time goes on, that's where you're starting to see onset of other various IRAEs. To highlight, though, some of them are occurring, and sometimes even with, say, a myocarditis, it was during the time of surgery. So it's really important, even when they've finished their neoadjuvant treatment, that the treating team still needs to be keeping contact, and also the surgical team also needs to be aware that this patient still is at risk of potentially developing an IRAE. So now with the establishment as standard of care with the Keynote 522 regimen using pembrolizumab, we're now getting evolving real-world data, and I'm sure more is going to be published on that. So I just wanted to demonstrate a couple of case series that have been presented. The one that's on the left is combined US and French case series that were looking at their IRAEs, comparing it with the Keynote 522 on the far left. And you can see the incidence was a little bit different, and the types were also a little bit different compared to what was originally reported. Similarly, on the right, this is a case series from the US as well. In their case series, their endocrinopathy side effect was nearly 50% out of all of their IRAEs, and it was mostly driven by hypo and hypothyroidism. Also wanted to highlight that we still need to think about IRAEs even when the patient's been on treatment for a long time, and even after you finish the checkpoint inhibitors. So this was a study presented at San Antonio a few years ago. This was looking at all checkpoint inhibitors, so not just pembrolizumab. So in their case series, they had 320 patients that they had. Approximately half of them had some type of IRAE during that time. And of those patients, 79 or 24% of them had a delayed onset IRAE, which was defined as onset more than 90 days after the onset of the immunotherapy. And as you can see, the median was 183 days and the range was huge. Compare that with the bottom bar, which is looking at patients who had post-treatment IRAEs, and that is any time greater than 60 days after completion of the immunotherapy. The median for that was actually 112 days. So 7.5% had an onset of an immune-related toxicity more than 60 days, and sometimes a long time after they completed their immunotherapy. Also to point out that of the 79 cases, 89% of them actually had a demonstrated IRAE earlier. So if a patient has an early onset for an IRAE, you still have to monitor for them because they may well develop another one as well. So I think we always have to go back to clinical trials, a little bit artificial and very defined populations, but also different populations in general. Underscores the need for very close monitoring, particularly blood tests for endocrinopathies, symptom assessment. You always have to ask the question, could this be an IRAE? And you still have to think about it even after they finish their treatment. So this is I think, quite a nice diagram for how to manage IRAE toxicity. I think education is absolutely critical to patients and caregivers. Also, what we do is, I'm sure a lot of places around the world do, they all have a card saying that they're having immunotherapy. So if they turn up to an emergency department, it's the emergency physicians know that they're not just looking for chemotherapy-related side effects. You need a low threshold to investigate. You always have to ask the question, could this be an IRAE? It may not be, but you still have to think about it. And also phone a friend if you really don't know. So subspecialties now are very well aware of all these toxicities as well. And there's also wonderful, well-established guidelines from a lot of the big cancer bodies. And continue to monitor. This is an example of the blood work that we do, or something similar, baseline bloods. I do them every 3 weeks before their treatment. Early morning collection's really important to capture appropriate cortisol, non-fasting, and I do a baseline echocardiogram on all these patients as well. That's sort of my routine. This is generally the general recommendations, pretty straightforward. If it's a low grade, you can often get away with steroid cream or low-dose oral steroids. Once you're getting into grade 2 or above, that's when you have to start thinking about discontinuation of the treatment. And the other thing I just want to comment on before I go into the case studies is the issue of fertility. It's still not particularly well answered. There are significant concerns from preclinical studies. This was a study that was done through Monash University in Melbourne a few years ago. And obviously much more research and data collection is needed, which is being done. So I think when you're talking to patients, young women of childbearing potential, you need to outline to them that there are some uncertainties of the effect of immunotherapy on fertility. I always do ovarian functional suppression with GnRH agonists on those women. And if it is available, I appreciate it's not always, fertility preservation, embryo freezing should be always considered. So I'm just going to give 3 different case studies of my patients. This is my first lady. She's 24, newly married, very fit and well, no other medical history of note. And she presented with a self-detected right breast lump. Imaging showed a single mass. There were multiple abnormal lymph nodes, level 1 only. On the PET scan, there was strong avidity, and core biopsy demonstrated triple negative disease, high Ki-67, moderately dense TIL infiltration, and an FNA of the largest node was positive. So that her imaging, her PET scan showed no evidence of distal metastases, but strong uptake in the breasts and nodes. So in the initial consultation, we discussed the Keynote 522 regimen, but I obviously stressed to her the issue of fertility. She offered her a review with our fertility specialist. However, she and her husband were absolutely adamant they weren't having children. Didn't change one, didn't want a consultation, which sort of set me back a bit, but obviously respected her wishes there. She did consent to having Gastellan as ovarian functional suppression because she's only 24. Don't want to put her into menopause just yet. So we did baseline blood echo was normal. There were no mutations found on a Bravo panel, and she proceeded to treatment. And she went through very nicely, but just coming towards the end, she had quite a dramatic infusion reaction from the pembrolizumab, had fevers, chills, needed IV fluids and a couple of days stay in the hospital. Whole body itchy rash, was pretty florid. Gave her some steroids for a few days. Everything settled down. When we got to cycle 7, she refused to have any more pembrolizumab. So we didn't do that. She had the final cycle in the neoadjuvant space. She had a complete metabolic response and breast and axillary nodes on the PET. Proceeded to her surgery and had a pathologic complete response in the breast. And the 6 nodes, some of them showed evidence of treatment effect. She underwent radiotherapy, and then I had a further discussion with her regarding having adjuvant pembrolizumab, which she heartily declined. And at that time, we ceased the Zoladex. I would have otherwise continued it. And she's steadily recovering, and she's remaining well back at work. Second lady's a bit older. So this is Mrs. B. She had a history of hypertension and intermittent atrial fibrillation, and she was already on metoprolol and apixaban. Strong positive family history of cardiovascular disease, but no family history of breast cancer. Had a screen-detected right breast cancer, and in fact, when she was seen by the breast surgeon, she had a palpable lump too. She had a spiculated lesion, and core biopsy again demonstrated a high-grade triple-negative breast cancer, and she had the breast lesion clipped. There was no evidence of any nodal abnormalities. So that's her mammogram, and that's her PET scan showing her avid node, but no distal metastases. Baseline bloods were normal. I did an echocardiogram on her, and she was in sinus rhythm, but the echo showed biatrial dilatation. She could climb 2 flights of stairs, but she said she was a little bit breathless at the top, probably more because she was a little bit overweight and unfit. Anyway, I referred her for a cardiology assessment first, and the cardiologist was happy for her to proceed. So she had her first dose in March of 2024. She tolerated well. She had no genetic mutations demonstrated. Prior to her second cycle, though, when I did a thyroid function test, she actually was a little bit hypothyroid. She was completely asymptomatic and actually said she felt really well. She had no palpitations. She remained in sinus rhythm. And at that stage, I elected to observe her. I mean, she was on metoprolol already and apixaban. I warned her about what to look out for. I was worried that she may go into atrial fibrillation. And she knew to contact the CDU or the 24-hour contact number if there was any problem. which there wasn't, thank goodness. And then I performed thyroid function tests weekly, then second weekly. You could argue that might be a little bit of overkill, but I was a bit worried about what may happen with her atrial fibrillation. And so we continued her treatment completely unchanged. And this is how everything progressed. So she was hypothyroid, and then, as we would usually expect to see at this point, she became hypothyroid a couple of months later. And that's when I commenced her on levothyroxine. She responded really well to the treatment. Unfortunately, struggled a lot with the AC pembrolizumab part with quite significant myelosuppression and required an admission to hospital, but she was fine. Got to her surgery and she was in a pathologic complete response. So 2 sentinel lymph nodes were completely clear, no evidence of any treatment effect. So she was truly no negative. Underwent her adjuvant radiotherapy, and then she continued on her adjuvant pembrolizumab. And she was doing really well until she got to the 6th dose of pembrolizumab, and she started to develop abnormal liver function tests, previously completely normal. Felt mildly unwell at that time, had chills and some abdominal discomfort and diarrhea, and a CT scan of her abdomen, because I was also worried whether or not she had a little bit of colitis, because she had quite significant episodes of diarrhea on and off. She had periportal edema in her liver, which would be consistent with immune-associated liver toxicity, but nothing else. Her hepatitis serology was negative, and I commenced on oral prednisolone, milligram per kilogram, then a wean, and there was a rapid improvement in her liver function test. I discontinued her pembrolizumab, and she is remaining well, but continuing on her thyroid replacement therapy. And the last case I was going to present, this is a lady, a 44-year-old lady, and she's originally from the Philippines. She's very fit and well, strongly positive family history of breast cancer, and in fact was subsequently found to carry a BRCA2 mutation. So in July, she presented with a self-detected breast lump and imaging demonstrating that she had level 1 and level 2 nodes as well, a very high-grade triple-negative breast cancer, FNA positive for malignancy, underwent her had a PET scan which showed intensely avid breast lesion, multiple nodes, no distal metastases, and baseline investigations were clear. And then she was commenced on the KEYNOTE-522 regimen. She went through the first 2 doses of weekly carboplatin and paclitaxel with really no problem at all. And then when I saw her at cycle 2, day 1, whilst most of her bloods were completely normal, she did have a little bit of an increase in her transaminases. And at the time, she was reporting a little bit more asthenia and nausea, and we increased her antiemetics. I elected just to watch her, and then by the following week, her transaminases had come up quite a bit more. So the question is this an IRA or is this actually paclitaxel? So because she was coming in weekly, I elected to dose reduce her paclitaxel. I did some investigations, including hepatitis serology, what's been performed pre-chemo. And liver ultrasound showed some mild fatty change, but that was all. And just reducing the paclitaxel dose by the following week, which was day 15 of the cycle, we had actually an improvement in her transaminases. And so elected to just continue as we were. And when we got to cycle 3, day 1, there'd been a further improvement. So at that stage, I proceeded to pembrolizumab in combination with the dose-reduced paclitaxel and unchanged carboplatin. And as time went on, her transaminases continued to improve. So I think all that was consistent with paclitaxel induced liver toxicity. So not all liver abnormalities is related to the immunotherapy. She completed all of her cycles of treatment and had complete resolution in her breast mass and lymphadenopathy. And her subsequent surgery, she had a bilateral mastectomy with immediate reconstruction, left TAD. She had a pathologic complete response in both breast and nodes. We completed her 6 months of adjuvant pembrolizumab with no problems whatsoever, and she is remaining well. So, in summary, really the monitoring management of patients during and after completion of KEYNOTE-522 regimen, ongoing surveillance is really important at baseline, and then you need to continue quite carefully throughout routine bloods during the treatment, low index of suspicion, and also reasonably excluding other possibilities. So, and particularly outlining, as we saw with the last case, there's a real overlap here too with chemotherapy-associated side effects as well, and you do have to try and tease it out a bit. Surveillance needs to continue for some time after completion of treatment. So I must admit, I still generally see them for the first year, probably end up seeing them probably every 3 months or so. And then also they know to be in contact if there's any change in how they are. I do add in hormone surveillance as well with part of those routine monitoring. If in doubt, always phone a friend. I always do. An early referral to appropriate subspecialty I think is really important. If you think it's an IRAE, early initiation of treatment, as we saw with our last case, you can afford to wait a week or two if we're trying to see how things turn out. But if you're sure that that's what it is, then I think you need to get on and treat. Ongoing data collection, particularly fertility, but also data collection for severe IRAEs is really important. And we need further guidelines for fertility in particular, and further studies, which of course are ongoing. And that's all I was going to say. Thank you very much for your attention.
Thanks, teaching. I invite you to go to the seat so that we can have the question and answer sessions. So is there any question from the audience with regards to the management, setting the stage for our patients that we treat in the clinic today with Keynote 522 regimen?
Yeah.
Okay, soon. Yeah, Rebecca.
Thanks so much for that great presentation. I think it gave us all a really good practical, what do we do in the real world? And I think especially the blood tests and how often to check them. And I also like the ask a friend. Friends are super helpful because you always get an honest answer from a friend. So I think my biggest struggle in my practice is the get a scan, and it's like a 1.8 centimeter triple negative breast cancer. And I say, we do an MRI, and it's really, you get that borderline. You clinically measure it, and you're trying to decide, because the subgroup analysis of the T2N0 showed really great benefit of immune checkpoint inhibition. So how do you manage that? Like, do you get an MRI? Do you measure it clinically? Like, how do you decide whether to take that patient to the surgery or try to give the neoadjuvant? And then when's the cutoff, like in your brain, for giving immunotherapy?
Oh, no, that's a great question. A great question, Rebecca. Yeah, I think it probably depends a little bit on the patient too. So I'm thinking of my first patient, for example, if it was like 19 millimeters, and I think I probably would be doing an MRI. I think it probably would be routinely anyway in those patients. And I mean, we have to follow fairly strict PBS guidelines in Australia. So, and it is kind of, you're supposed to follow the 522 regimen pretty much by the letter. So I think for those patients, you probably try as much as possible to, various modalities, maybe even the PETs, if I measure it a bit differently. But otherwise, I think I probably do try and adhere, although you just don't know. And, it's such a quandary, isn't it?
I have a question regarding side effect management. So, Keynote 522 was done before when, during adjuvant pembrolizumab, they didn't allow for you to combine it with capecitabine or nab-paclitaxel, but we are doing it today, although we don't have a lot of data there, but we are doing it. Do you see more side effects from the combining? And how do you plan your monitoring, since people are giving together with capecitabine and all together with olaparib? Does it change or is it the same?
I think I kind of still do more monitoring for the endocrinopathy. So I think I still stick with the 3-weekly endocrinopathy assessment and do more rigorous blood testing than I would have done if a patient was on capecitabine. I actually haven't seen that much difference in terms of toxicity, which is really reassuring. I think that's in line with, what other reports as well. So that's really reassuring. And the big question is, like, can you combine it with olaparib? In Australia, we're not allowed to. And so it is always a quandary when you have patients with BRCA1, BRCA2 mutations. What do you do? And that's a very, very difficult thing to answer. I think you have to go case by case. But no, I've actually found, to my reassurance, that it's quite fine to do. So I definitely offer that to my patients.
Okay, so this is very practical for us when patients are on the adjuvant pembrolizumab. you also do the monitoring for the thyroid function test every cycle?
I do. Yes, I do. And again, maybe my endocrinology colleagues might think I'm overkilling a bit, but you still do see a steady stream of immune-related toxicity, even when you're quite comfortable, think this patient's going to be fine, and something pops up. So I actually do think you need to just do that a little bit more frequently.
And after that, when they finish the pembrolizumab and so on, follow up. So now this is a patient that we are curing. So we are going to see them maybe every 3 months. So you do that every 3 months.
I do. I would do that each time. I'm someone, I do tend to do blood tests. Again, it's maybe a little bit contrary to guidelines, but patients do like a blood test, so I tend to do one. And I just add that on with all of our tests. So I do thyroid and I do cortisol. Tell them to do it in the morning. I have picked up one hypothyroidism subsequently, and I have also been made aware, even beyond that, like a colleague of mine who got told about one of her patients who had a very bad rash, and everyone was putting it down to something different. And in fact, it was immune-related toxicity more than a year after they completed pembrolizumab. So put them on steroids and it got better.
To be careful. I realized that your second case had 3 RAEs, right? So I want to know, what is our threshold? When do we actually stop? After 2? I mean, there was after 3.
She was a very motivated lady.
So yeah, so that comes to the second conversation. How do you communicate? How do you converse with your patients when they have a few, immune-related AEs? And yeah, how do you convince them to stay motivated? I want to learn.
Yeah, so look, I think it depends on the individual. I mean, some patients, like with my young lady, it was like it was quite a nasty reaction, but she just went, that's it, and I'm not doing that anymore. And then obviously respected decision. She's doing well, and she's got CAT-CR. With the older lady, she was very keen to do as much as humanly possible, and had a friend who died quite tragically of breast cancer quite young. And so she really wanted to do all she could. So yeah, we have those conversations each time and say this, you may have another one. You've had one quite early, you might have another one. She was very motivated to keep going, including she had a pathologic complete response. And I discussed again about the adjuvant situation and the unknowns there. She was very motivated to keep going. When we got to the liver toxicity, I said, look, we're not doing any more now.
Yeah, scarces. Because we have a lot of liver, fatty liver in Malaysia. We also have a lot of hepatitis carriers. So yeah, hepatitis, immune-related hepatitis really scares me.
I can understand that. It can be very scary when it happens because it can happen so quickly.
Any question for the audience? Otherwise, I will indulge myself. Yeah, Isaac.
Hi, Lee from Penang. So just a very quick case. So I've got a patient who is a clinical T2N3 triple negative breast cancer. So at chemo 522. So at cycle 2AC had grade 3 transaminitis. So the transaminitis cleared with steroids, had surgery, had residual disease. A couple of notes were positive and about a 1 cm tumor in the breast. Would you re-challenge with pembro? And if you do, how often you will monitor them, and what's your experience in terms of recurrent transaminitis?
So sorry, just to be clear, it was skin toxicity was the main
Transaminitis, a grade 3 transaminitis was admitted to hospital, had steroids, and it cleared, so resolved, but she's essentially very high risk. So would you actually re-challenge with pembro? And if you do, what's your experience with recurrent transaminitis? And
I think if it was grade 3 transaminitis, I wouldn't re-challenge. So I think the odds of this happening again would be over 50%, and someone's could even be worse, which is especially terrifying. So I think I would leave it there. I mean, obviously you've got to be concerned they've not responded as well as you would have hoped. I think in that situation, of course, we've got capecitabine or olaparib if they're BRCA1, BRCA2 mutation carrier, or clinical trial. And there's a few very good clinical trials like the TROPHUSE, about 12 trial looking at residual disease. Although, of course, you're supposed to be eligible for the pembrolizumab, but there would be other trials, I think, ongoing as well. I think at the moment, in terms of standard of care, I think it's kind of left with capecitabine, unfortunately. I'd be way too nervous myself.
I also have one clinical case to discuss. Actually, I was actually on the way to come here at the airport when my gastroenterologist called me up regarding one of my patients that I referred. So this lady is a 60-year-old. She didn't have she wasn't even nodal positive. She was about 3.5 centimeter tumor, no lymph nodes. So she had neoadjuvant KEYNOTE-522, and she has had surgery. It's not PCR. In fact, she's RCB3. So while waiting for her decision regarding the adjuvant treatment, we wanted to put her in the clinical trial for the SEC-TMT, but waiting for her decision, she couldn't decide. So I gave her one cycle of adjuvant pembro, and the subsequent cycle, now meaning that this is now pembro cycle 10, because she has 8. So I had one more post-op. Then the 10, I discussed adding capecitabine because I'm very worried about her disease. So she had the capecitabine, but she came to my clinic because she had some PR bleeding. It's not like PR bleeding. PR bleeding is just a mucus, very mucousy, and like a blood. So referred to the gastro, and he called me just as I was on the way here to say that she has like somewhat like inflammatory bowel. She said it's not IBD, but it's like the bowel doesn't look so good. So stop the capecitabine, continue the pembro, which I'm not sure whether it's autoimmune colitis, but I asked him to actually biopsy the areas, and probably on Monday after. Let's have a look at what do you think?
Oh gosh. Yeah, I mean, obviously, as you say, both agents could be the culprit. I think the biopsy is going to be really critical there, and you're understandably very worried about her risk of recurrence.
She doesn't have any significant comorbidity. She didn't have any problem when I gave her the KEYNOTE-522 regimen. She didn't have it when I gave one cycle post-op, just as when I started with capecitabine.
Yeah. So, and I mean, you could give her a trial of steroids, or if it wasn't too severe, you could give her a trial of steroids anyway. Obviously, wait and see what the bioevidence shows, and maybe there was obviously a lot of lymphocytes infiltrated. I guess it gives you the answer. But I think that's probably going to draw a new decision.
Yeah, I wonder whether anyone has actually experienced anything like that. Like this, with capecitabine.
So I think we know that patients can get colitis, either with or without the pembro. But I did have one patient. Actually, I find that after KEYNOTE-522, trying to deliver capecitabine, trying to give a laparoscope is a lot more challenging than before. And I think it's because they're getting a lot more chemo, and perhaps our patients in Asia have more myelosuppression. But I do find I struggle a little bit with the delivery, and I've had to go to a metronomic schedule of the capecitabine at times if they don't tolerate the traditional schedule. So I usually, if you've got 2 agents on board, just stick to one, and then so I probably continue the pembro, give her some steroids. If it resolves, then consider giving her the cape again. But even the gastro doctors are struggling sometimes to know what's what. I've got patients scoped. Is it not? If in doubt, just give a course of steroids and see how it goes. I mean, to be honest, that's what I usually do.
Thank you. I think that's for one last question.
Good.
I'm I'm a medical oncologist from Taiwan. I have 2 questions I ask speakers and moderators' opinion. The first is that what's your opinion about the chemo part in KEYNOTE-522 regimen? Because in rural practice, we seldom to encounter infusion reaction to pembrolizumab or anthracycline. However, we do encounter infusion reaction to paclitaxel. So how about your opinion to replace paclitaxel with paclitaxel or what? And is this? And some patients in Taiwan, it is difficult for them to come to hospital weekly for weekly taxol. So what's your opinion about trying repeat docetaxel to replace weekly taxol? Yes, it's a key part. And the second is that has any surgeons give their opinions about the patients? Those patients receive neoadjuvant immunotherapy. During the surgery, they were found probably lymph node enlarged, probably due to immune response or pseudoprogression issues in early breast cancer? Thank you.
Think the subway business. Does that question? I got the fifth. Can you repeat the second question? You did.
The second one is for breast surgeons. Have there any correspondence to after gone response to you that when the patient receive immunotherapy and adjuvant setting, the breast surgeon encounter any situation during that means, for example, they smell may enlarge or they thought it was tumor. However, after the surgery found it's complete response.
I guess to answer the first question, thank you for those questions. I think to answer the first question, I have had a few paclitaxel reactions. We're actually limited on the PBS. We're supposed to stay with the chemo as defined in 522. So I don't have the scope to change. But from experience from other tumours or other treatments, I've often found that they often still react with the other taxanes anyway. I think a heavy pre-medication or heavier pre-medication is sometimes useful, slower infusions. If you're really concerned, the other thing is you could always drop the paclitaxel. You could continue with the carboplatin with the Immunotherapy. And I mean, that did need to happen on a reasonable frequency on the 522 regimen anyway. So the second part of the question, yeah, we have had that. The surgeon's gone in and they've said all these enlarged lymph nodes, and they've taken them out, and it's all been sort of lymphoid reaction. So sometimes, I guess, the question is, will we need to do sort of more extensive auxiliary treatment because the surgeon's worried about what they find at the time? That hasn't happened with a huge frequency. I can think of a couple of cases where when we reviewed it at the multidisciplinary meeting, and in fact, they had, a quite significant chunky nodes that were all just lymphoid and no evidence of tumour.
Thank you.
Thank you.
Thank you. So thank you, Dr. Jackie, for the excellent presentation, as well as answering all the valid questions that we have today. So please thank Dr. Jackie really so much. Thanks, Siri.